Hey there, spooky friends, and welcome to another episode of the Scaryish podcast.
Woo.
This week, well, I'm Robin Grace, this is Adam Diaz,
Hello.
and this week we have a very special guest, a returning guest, one of our very own spooky fam, Faye. She's definitely one of our favorite people, and we're so happy that she's generously offered some of her free time to share some crazy stories with us.
Woo! Thank you so much for having me. I'm very excited to be back on the podcast.
So excited to
We're
have
very
you back.
excited.
Yay. Faye, for full disclosure, Faye reached out and was like, I have a story. Is it okay if I share it with you guys on the show? And we're like, please, God, yes. Like, that sounds awesome because your last episode was so good. I know we were talking before the show and you were saying this was originally homegrown horror that you were going to send in, and you just saw the length of it and you're like, this is more of a topic.
Yeah, so I actually have two stories for you guys today. One that is a personal story that I was going to send in, and then I was like, this is way too long. They're going to not want to read this on the podcast because it's way too long for an actual homegrown horror. But it was too short for a full episode. So then I was like, what else is Scaryish in the medical world, and came up with the second story. So full disclosure, I got two stories for you guys. Hopefully it will be enough for a full-length episode.
We're super excited, and we're on the new format now where we're only doing one topic per person, which is kind of keeping us going, keeping it fresh, and less pressure on us to find topics having gone through over 500. So we're super excited.
Well, yeah, I think a big thing for us too recently is focusing more on our mental health. So when we need a break or something like that, we're taking the time to do that, because sometimes everyone needs a break. Everyone needs, some time to reflect and chill and stress less.
Yeah, absolutely.
Yeah, it was such great timing that you reached out. I was so happy. I was so excited. One, awesome. Can't wait to hear your story. Two, it's this is a week that we don't have to stress. We can kick back. We can listen. We can be the spooky friends, and you're in charge, Faye.
Oh, gosh,
we should just start this shit all over, and you can just create a new intro.
No.
You can do whatever you want. You're taking over the reins.
Too much responsibility. It's too scary.
So I think it's been a minute since we've been on the air. So we can just do our normal recap of stuff that we've been up to. I think the last time we were on, I announced that I had a new job. I don't know if I actually announced that or not. So yeah, starting a new job super soon. There's a ton of stuff on my plate to get rid of my old job's responsibilities and then get into the new thing. So it's been a ton of stuff, but I'm super excited about that. Outside of that, my brain can't even process what else has been going on. So 4th of July happened. That was cool. It was very cool. Noisy. Our dogs absolutely hated it.
Spooky Mom broke her collarbone. That was...
Yep, Spooky Mom. I was going to say that one too. Spooky Mom had a little bit of a spill on a bike, so everyone send your spirit bomb energies to Spooky Mom so she can heal. She has a broken collarbone right now, but she should be on the mend. So, yeah, outside of that, Robin, did I miss anything? What's going on your end?
If anybody knows anyone real nice, Spooky Sis, looking for a boyfriend, hey.
Wow. Just putting her out there on the market. Interesting. Spooky Craigslist. Hit her up. No.
Craigslist? No.
Spooky Craigslist. It's got to be nicer than real Craigslist.
Spooky Tinder.
I've gotten coffee tables.
Yeah, Spooky Tinder.
Man, we got to come up with a better name. Faye, it's been a minute since you've been on the show.
Yeah.
You don't have to give full life updates, but you originally I wouldn't say did everything. I think you did 98% of SpookyCon 2021, I think it was, out in Philadelphia, right?
Yes.
Since then, we haven't had another SpookyCon. We've been talking about it a little bit because you're located in a different area now, and maybe we'll have something coming up when it comes to that. But behind the scenes, Faye's always talking to us and giving us ideas for things. So super grateful. But you've had a bunch of life changes.
I have.
Right?
Yeah. I mean, I think the last time I was on the show, it was 2022. So I have since moved across the country. I now live in Portland, Oregon. I have a 9-month-old now. So,
I can't believe he's
I know. I was like, oh
months.
my God, he's so old. He's almost a year.
I know.
He's not
he's
that
so
old.
He's basically got to
to
move out, start looking for jobs.
I was going to say, he probably has a 401k already,
yeah,
right?
Exactly. Yeah, I have a job out here. We bought a house. Yeah, I did lots
of life changes.
So much.
All of the adult things. Yeah.
Well, you're killing it, and we're so glad that you're here, and super excited for whatever's going to come in the future when it comes to future SpookyCon stuff, because you have so many great ideas. So I just want to say from the bottom of my heart, thank you.
Yes.
And also thank you for being on Twats at Twats, the Wheel of Time show about the Wheel of Time show, because that was a project near and dear to my heart, my friend Garrett's heart. And Faye was originally just going to be like our third chair, like maybe she'd pop on, and she like blazed through 14 books, was like, I run this bitch now. And she's like an official mainstay in charge of that show.
She has my favorite section of the show for me.
Who's hot
on Twat?
Where she just goes over who, based off of looks or actions, was the hottest person in the specific episode.
Yes, exactly. Though I will say, I think what makes it really cool is Garrett's little intro, like the hot on Twat.
He's so good at producing stuff. He
really
absolutely is. He's okay as a host, but producing, he's genius.
Love you, Garrett.
He's listening right now, and he's probably just like, I hate him so much. But all right, we've bloviated, we've bullshitted enough. I think it's time for us to turn the reins over to Faye. Let us know what we're in store for, and then just like, I guess, jump into it.
Yeah, sure. So I have 2 stories, like I said. The first story is a personal story. It's not scary, supernatural, or anything like that, but it is a personal story that I have from the medical world. And there is some discussion of pregnancy and fetal death. So I just want to put that out there. You know, if that's something that you don't want to listen to, maybe skip to the next story in the next 30 minutes or something. Okay. Well, so before I start some of this story, I kind of want to give a little bit of background, because I think, you know, not everybody knows about all of this, like, viability stuff. So I thought I would give a little bit of history. So, you know, some of you know that like the gestational age of viability is 24 weeks, right? So that just means that a baby, if they need to be delivered at 24 weeks for whatever reason, there are a lot of NICUs or neonatal intensive care units in the world that would offer them what we call resuscitation. So that just means things like things the baby needs to survive in this world. So like a breathing tube that they put down into the baby's throat if they need it to breathe, using machines to help the baby feed, putting the baby in an incubator, all of those types of things. And, you know, it's not a guarantee that a 24-week baby would survive, but at least all these resuscitative measures can be offered, if that makes sense. And this really became the standard for viability. I put that in kind of air quotes, because when it was decided, like, hey, when are we going to start being able to offer this this resuscitation, it was at the time approximately 50% of babies, if they're born at 24 weeks, so just, you know, right around the 6-month mark, 50% of those babies would survive. But, you know, nowadays, now that we are many years from that decision of when this quote unquote viability is, with the advances in medical technology, there are some NICUs that will actually offer resuscitative measures for babies that are born even earlier than 24 weeks. So like as early in some places as 22 weeks, which is like a little crazy to me, because that's like 5.5 months, right? Like,
so can you let me know,
yeah,
as a person who has not had a child and does not have a vagina,
I think it's mostly the uterus part of it.
At 22 weeks, like I've seen like the diagrams, like this is what your baby has at 24 weeks or whatever before. So what's so different about this 22-week mark compared to 26?
Right. So just to kind of put this out there, full term, you know, we think is 9 months, 40 weeks, for example. Full term can start anywhere from 37 weeks onward. So babies that are born after that usually are totally fine, you know, don't really need a lot of like resuscitation or anything. Babies that you can just take home potentially, not to say 100% of the time. Babies born before that are considered premature. Basically, at that time, 22 weeks plus onwards, all the organs of the babies have developed, meaning like they have lungs, they have hearts, they have stomachs, they have intestines, but all of it is just very immature, if that makes sense. So the lungs aren't potentially developed to the point yet where they could breathe on their own, where they can do adequate like exchange of like oxygen with carbon dioxide, which is like what our lungs do, right? Their guts might not be, you know, they might not be at the point where they can actually digest food, for example, like, or digest milk even. You know, their brains aren't developed. Their skin is like just papery thin. It's not good at preventing them from getting infections like our skin is. And so obviously there's no like difference between 22 weeks, 0 days, and 22 weeks in 1 day. But as you can imagine, every single day that the baby gets, like more of these organs start to advance and start to work a little bit better. And a lot of this also has to do with size. So you can imagine a 22-week baby, you know, that's a baby that's potentially under a pound, right?
Oh
so
my
at a certain
gosh.
point, at a certain point, we just don't have a tube that's small enough, right? If a baby can't use their lungs to breathe and we have to help them breathe, well, they have to be put on a ventilator. They need to have a tube that's put in their throat to help them breathe. You can imagine at a certain point, we just don't have a tube that's small enough, right? And so that is going to be your limitations, for example, if that makes sense.
Yeah, I can't imagine how tiny
under
a baby
a
would
pound.
Mm-hmm. Yeah.
I've had steaks bigger than that. You know what I mean? Like, that is so small for a little person.
Yeah. And, you know, so like as someone who's like delivered some of these babies, it's really a wonder that they can survive because, you know, you're delivering a baby who's going to like fit in the palm of your hand. And so just with all the medical technology that we have, right, like we now have the ability to help resuscitate some of these babies at even 22 weeks. But the caveat to all of this, right, is like we could push that potentially that viability or where we offer some resuscitation. So we offer trying to put in a tube, offer putting them in an incubator. But it doesn't mean necessarily that the baby is going to survive just because we can put in a tube to help them breathe. Does that make sense? Because we might be able to do those things, but if your lungs are so immature that they can't exchange oxygen and carbon dioxide effectively, no matter how much oxygen we shove into that breathing tube, like, you know, if you're not able to get that to the rest of your body because you're just so immature or premature that you just can't do that, you're not going to survive. And that's kind of where we're at with those 22-week babies. So the survival rate is really, really low for these 22-week babies. And the thing that I think a lot of families need to know is that the survival being neurologically intact, meaning survival in a way where that baby could leave the neonatal ICU, leave the hospital, go on to walk and talk and go to school. That chance is really low at 22 weeks, somewhere between 5 to 10%.
Wow.
Right?
That's so low.
It's really low. And so, you know, for this reason, between 22 to 25 weeks, we call this periviability, so that even though these babies could survive, it doesn't mean that they will survive. And often, even the ones that do survive will have some significant challenges in their life. Like they may never leave the hospital. They may have something like cerebral palsy. They may have blindness or deafness. Very possible for them to never be able to walk or talk or go to school. And so because of this kind of difficulty, you can imagine that there are a lot of families out there who would say, hey, knowing that, right? Like, I don't want my child, if for whatever reason I have to deliver in this time period, to suffer and potentially still pass away in the hospital. So they may not want all these medical interventions like putting tubes in, chest compressions, all of those things. And they might want to just spend as much time as they possibly can with their babies without all of these medical interventions, just to kind of spend as much time as they can without the baby suffering, right? Like in this time period. There are families that choose that, yes, we want all the interventions. And then there's families that say, you know, maybe I don't want all of those interventions. And so you can imagine, like, this part of my job is probably the hardest part of my job, where you're trying to counsel people because, of course, I think everyone's instinct when they come in and they're pregnant and either they're in preterm labor or they have other reasons to deliver at this time is they might say, do everything you possibly can. And then you kind of have to be the one to say, well, this is what everything we can looks like, but these are the outcomes. And really, you know, what is it that your family values? And so, like,
that's so hard.
It's such a difficult conversation because people will ask me, well, what would you do? And I would say, I have very different values potentially from you. Right. So I can't answer that question because maybe for me, I might say, you know what, if my child can't go to kindergarten or they can't go to college, or, you know, they're going to spend the rest of their life in a hospital, like maybe for me, I wouldn't want to do all of these interventions. But maybe some people would say, yeah, they do. They want to have all those interventions for that 5 to 10% chance, right? So anyway,
I find it so fascinating that there's like so many folks out there that, like, I have family that I've spoken to who've just told me very directly, like, I have a DNR. You know, if there's a decision that needs to be made, like, I have already made that decision that I do not want to be resuscitated. Like, I just don't want to be brought back through specific technology, and they've sat down and talked to their loved ones and people that are going to be around them if something like that were to happen. And the idea that you have to make that decision during the developmental stages of your child, you know, suddenly it goes from you think that you're a few months away from having your kid born to now you're deciding whether or not like you're essentially doing a DNR. I'm very glad you're walking us through this with as much information as possible, because this is really good stuff to know. I feel like a lot of people don't know this until they're confronted with the decision. Like, here's an avalanche of information, and now you have to make the hardest decision of your life. So
yeah, and that's kind of like what I walk into every day. And so the reason I'm bringing up the story is because this is exactly what happened to me when I walked into my shift one morning. And so one of the patients that I was coming on to who had been admitted overnight, we can call her Claudia, that's not her real name. So she had been transferred from her local hospital. She had broken her water. And her cervix was dilating, and she was 22 weeks and 4 days. So she was in that peri-viability period between 22 and 25 weeks. She was laboring. She was already 4 to 5 centimeters dilated, and her baby was breech, so meaning butt down and head up, right? And this is a really difficult situation already. She's laboring. She's about to deliver this 22-weeker. But in her case, right, if she were term, if she was 39 weeks, say, and this was happening to her, she came in, her baby was breech, we would recommend to do a C-section in the United States, because there's been documented studies that show that babies who are born breech are at higher risks of like having neonatal complications. So things like the head getting trapped, in the cervix, and when the rest of the body has delivered, having like worse respiratory outcomes, all of these things. But at 22 weeks, because of all those like scary things that I talk about, those babies, when they're born breech, the outcomes aren't necessarily better if we do a C-section. And, you guys probably say, well, everybody knows someone who's had a C-section, right? It's such a common surgery. But I always tell people that just because it's common doesn't mean that it's not a big deal. It's a huge abdominal surgery. We're cutting somebody open. It's major abdominal surgery. And so oftentimes I tell people, if the outcome isn't going to be different for the baby, then maybe we should consider not doing a C-section, because then it's this major morbidity for the birthing person, right? For the mom, because you are going to have major abdominal surgery, you're going to have more bleeding than a vaginal delivery, more risk of infection, potentially like higher risk of injury to your other organs. And so, after we talked about all of this patient was like, hey, you know what? Maybe I'll just labor, and maybe I'll just try and deliver this baby breech. And, if that happens, that happens. So, we talked to her for a really long time. We kind of walked her through all the options. She met with, our NICU. She met with us. She decided, you know what? I am going to try and just labor. I'm going to deliver this baby breech. When the baby comes out, whatever the baby looks like, then, the NICU will come and they'll see if they can try some resuscitative measures. And then several hours later, the nurse comes in to kind of check in on her, see how she's doing. She's got an epidural, so she's more comfortable now. And she's searching for the heart tones, and she can't find the heart tones for the baby.
Oh, no.
So our team comes in, we're going to confirm the finding of no heart tones with the ultrasound. We actually bring in the ultrasound to scan. And her whole family was there, obviously, because this was such, such a huge thing that was happening for them. And then, you get that air that just goes out of the room, because I put the ultrasound probe on her belly. There's another doctor standing next to me, and we kind of both confirm that there's no heartbeat. And so I had to tell her this very unfortunate news that, her baby had passed away during labor. We offered our condolences. And this is just the hardest part of the job, right? Where you have to tell someone that their baby has passed away. And then when this happens, though, you still, the person still has to birth the baby, right? There's no other way to go about this to remove the pregnancy. And so, we gave her our condolences. We talked to her about our recommendations. We recommended some medicine to speed up the labor process. And several hours later, she actually felt the urge to push. We went back into the room for the delivery. She pushed once, and she pushed the baby out. And we were there, we were in the room, we were ready to kind of wrap the baby up in the blankets, let her spend time with her baby. No pediatricians in the room, because, we had thought that the baby had died. But then as soon as the baby delivered, my resident kind of looked up at me, and I looked down, and we both looked down. We had both confirmed that there was no heart tones on the ultrasound, but the baby was moving.
Oh, wow.
And then let out a cry.
Wow.
And so
I want to edit in clapping.
Yeah, right.
Hooray.
Right. So
like that was like so stressful. Oh, hey.
right. And so,
Oh my God.
well, then the next few minutes were really stressful because there were no pediatricians in the room. It's like, so I'm an obstetrician. My residents are obstetricians. We're great when the baby is inside of you. Once they come out, we're like, not our job anymore.
Please take this and fix it, please.
So we're like stimulating this very teeny tiny 22-week baby. Meanwhile, we're like pressing the levers for like emergency, emergency. We need the pediatricians right now. So like, the neonatologists like come running in several minutes later. We have this tiny baby. We're trying to tell the patient like, oh, your baby is alive. We're calling the neonatologist. A lot of people are going to come in right now. So they all rush in. They, take the baby who's very much alive, who's crying and moving. They're resuscitating the baby, taking her out to the NICU. And I just felt like this was such a crazy story for me because, I'm not religious at all. But I really have no idea how that baby was alive. Like after two physicians, including myself, basically confirmed no heartbeat on ultrasound for a full minute. And so, the amazing thing about this is that this baby still happens to be alive, is still doing very well in the NICU.
Woo, that's great.
Awesome.
Yeah.
That's so awesome.
And, this experience obviously taught me that we definitely don't know everything as doctors, and there's still cases that surprise us. But this was one of those things that I felt like there was maybe like a little mixture of like science and I don't want to say the paranormal, but some type of, I don't know, like higher being intervention. Cause like I had never seen a baby come back to life before.
That's
I've always
really
wanted
cool.
to like talk. I can't find a whole lot of stuff online when I do research, but sometimes I'll just like Google like medically confirmed miracles just to see what like comes up. And so rarely do you find something that's real. You find stuff like on a Reddit forum where it's someone's anecdote that you can't confirm. So this is absolutely incredible. So that's super awesome. I think I use that word miracle because I was raised fairly religious. I, have a different view of it now, very much so. But it's one of those things where it's like, well, we don't really have a word for it. It's like something that should have been one way just was a different way with no real explanation as to what happened, except that the thing that everyone would have hoped and prayed for is what happened. So I just like to apply that term based off my background. So I'm just going to say medical miracle confirmed.
And I mean, the nice thing for this patient and her family, they were very religious and they were kind of praying the whole time that she was in labor. And for them, this was their miracle, right? This was like an act of God for them that their baby was alive. So, I mean, it was very lovely. And I never, I never want bad things to happen, but, I'm realistic. And so this was just a very, very welcome surprise that I was absolutely not expecting.
That is so cool. It's so nice to know that they're still, alive and going through it. So,
and it really does give people hope too, like going through like really sad, really dark situations. Like I can appreciate, like I've watched Grey's Anatomy a couple of times. Like I can understand, realistically, like I can understand that I don't think I could ever be a doctor based off of those moments and how difficult they must be to navigate through while still doing something that's incredibly important and very difficult to do. So the fact that you are realistic, I think, speaks to the fact that you can do that. It's not something I think a lot of people can do, but the fact that you were rational and you went through and made the steps and offered the options, I do think that's sort of the reason why that medical miracle was like able to happen. Like there was the capacity for that because you were educated and you gave the options properly and the person listened to you and trusted you. And then through your, like you said, like through your scientific education and through their faith, like those things combine for like the perfect outcome in a very difficult situation. So that's incredible.
I can't even imagine being in your situation.
No, I mean, I think, the biggest thing I feel like is I'm very good at compartmentalizing. It's like work stays at work. When I come home, we like cut that off and then move on with my life.
No, I think it's probably a very necessary thing, especially specifically with your specialty. It's something where I think a lot of people would lose their minds. Even most doctors, I think, would be kind of terrified in that situation where it's like, okay, I kind of know what to do here, but this is intense as hell. And there's just so much writing on the line. So compartmentalization, probably something that all of us could use.
Yeah, I wish I had more of that, because I swear if I have one bad day where a developer yells at me, I'm talking to Adam about it all night and how upset I am
And
about
she'll
it.
be mean to me, like she'll be on the phone on the car ride home, and she'll just be like saying things. I'm like, "What? How was your day? Like, tell me what happened so I can understand why you're being mean to me right now."
But yeah, thank you so much for sharing that experience. I think that's really cool that it's like gives people a little bit more hope, you know?
Yeah, I do think so. And I think like looking back on this, I don't know if you guys remember the stories that I told you last time around. I think my first story that I told you guys, if you remember, was like the Rhode Island human chandelier disaster when I was a medical student and had no idea what to do. So I think it was interesting because when I was writing this, I had just listened to that episode and I was like, wow, I feel like I've come a really long way in my medical training, where I was like, had no idea what to do. It was my very first day on that clerkship. I was asking people like, hey, how does that make you feel? Because I just came off of psychiatry. So I do feel like I was like, oh, I have had some growth in my life. That's good to see.
You know, it's funny. I was thinking about that, I think a couple of weeks before you reached out about doing an episode with us, because I think about the second part that you told us. I think it was the second part. Regarding like the way things were handled in California and the way women's health was handled, where basically people were just having their tubes tied, like without their permission or consent. Like, oh, we're just going to go ahead and do this. Just thinking like, God damn, like things are so fucked up and have been in this country in so many different ways. Like, it's fine to take a snapshot right now and see things aren't how you want them to be and things look bleak. And when people talk about like the good old days, like, no, they really weren't good old days. They were pretty fucking awful. Like, no matter how bad things seem now, it's like marching forward through time. I was like trying to give myself hope basically for how fucked up things are right now. And I just remember thinking about that very specifically. Like, we don't do that shit anymore. Like, I don't think there's any way we could go back to that, but who the hell knows? Because that really did stick with me, that specific topic. So
yeah,
I'm excited to hear the second portion of what you have to tell us tonight.
Yeah. Well, so actually my second story, it doesn't have anything to do exactly with that story that you're talking about, Adam, but it also brushes on the part of like women's health and like how we've gotten to where we're here today in terms of women's health. So hopefully you'll find this as like cool as the last story that I told you about women's health before. So my second story is the story of J. Marion Sims. So J. Marion Sims was an American physician and surgeon who was most famous for his work in the field of gynecology, and he's often called the father of gynecology. And even now has like yeah,
right, that's a weird title.
It is kind of a weird title, but he has like instruments named after him. Like he is like a guy that has like really pushed forward the field of gynecology and brought it to, you know, where it is today. He has an instrument named after him called the Sims speculum. J. Marion Sims speculum. So, you know, yeah, if you work hard,
is
kids,
that the
you can also
speculum
have,
that we see normally?
It's actually not the speculum that you normally see in the doctor's office. Like, you know what I'm talking about, like the duck bills?
Yeah.
It looks like the bottom half of the duck bills, if that makes sense.
Dare I ask, what's a speculum?
Oh, gosh.
You can laugh all you want. I'm very ignorant.
Wait, no, there's no way you don't know what this is.
I mean, I probably have seen multiple instruments used in women's health, but don't know the name of them. So I heard duckbill, and I think I have an idea.
Yeah, so you hopefully have never had this exam before, Adam. But when people with vaginas and cervixes or women go to the doctor, they usually will get a pap smear or a pelvic exam. And to see the cervix, we put in what's called a speculum. And so it's this instrument that looks like it's got duck bills, and then it can open up like this, like kind of
it's like that
jaws.
trick you do with your hands.
Oh,
you just
stop
like open it up. So
You're so stupid. No.
We actually just watched an episode of the TV show Letterkenny, which is on Hulu, where the guys were complaining about the fact that they had to get prostate exams, and two of the female characters very descriptively go over the process of getting a pap smear. And by the end of going over it, all the guys realize that they're little whiny bitches.
That they would rather get prostate exams. Here, Adam,
Yeah.
I've dropped a picture into the chat. You can put that onto...
Oh, goody.
you can put that onto the Instagram, for example, if you would like to.
This is...
I need to click on it.
It's very interesting.
Oh, yeah, that's fine.
It's very interesting how the difference between men and women, because Robin tells me very consistently at least 5 days out of the month how lucky I am to be a man.
Oh yeah, I just told him this earlier today. I think.
And I'm aware of that. I don't think in any way, shape, or form where I'm just like, no, I don't know. I think it's pretty no. It's super easy to be a dude. But seeing things like this, it's like, man, women's health and the things y'all go through is definitely difficult, and I have nothing but respect because this thing looks like it came straight up out of a torture chamber.
It really does look like a medieval torture device, and I apologize. So the Sims speculum it basically looks like the bottom half of that speculum. So if you remove the top duckbill, that's what a Sims speculum kind of looks like.
What is that for? If there's just the bottom, because this one opens up.
Yeah, so the bottom is to just go into the posterior portion of the vagina and just pull down so you can just look at the posterior portion.
Huh.
Anyway.
All right.
Yeah.
Bits and bobbles.
Adam's like, what in the
No, I'm like, I know the words posterior and anterior, so I'm deciding in my brain which ones I think are which. Like, based off of my understanding of the orientation.
Hold on, let me drop the picture of it into the
chat. I think that might get you guys like banned or something. You can't put pictures
yeah, that would be the end of our Instagram account for sure.
Maybe I can send you guys a picture of J. Marion Sims instead.
That's perfect.
Okay. So after all that, you're probably like, why are you talking about this? Because this is a Scaryish podcast. It's not a history podcast. It's not Sawbones. It's not a vagina podcast. But there is actually a darker, Scaryish side to his story. So I'm going to get into that. But let's start from the beginning. So Sims, J. Marion Sims, was born in 1813. So he was born in the 19th century. He was born in a place called Lancaster County, South Carolina. His first name is James. He prefers to go by his middle name, Marion. Born to a long line of American war heroes. So his father, Colonel John Sims, was basically participated in the War of 1812, and his paternal grandfather was one of Brigadier General Francis Marion's men. And Francis Marion, for any of those history buffs out there, he was part of the Revolutionary War, and he was the one that came up with all of those like guerrilla warfare tactics that the American soldiers did, and which basically helped them win the war against the British, who were still very much in that like marching order, like coming in with their muskets and stuff like that.
Okay.
So anyway, Francis Marion, father of guerrilla and maneuver warfare. So very fancy. All right, so back to J. Marion Sims. So after he grew up in South Carolina and going to college there, he then moved to Philadelphia, Pennsylvania in 1834 and enrolled in Jefferson Medical College, from which he graduated in 1835. He was actually described at that time as a lackluster student who showed little ambition after receiving his medical degree. And I'd also like to point out that he started medical school in 1834 and he graduated in 1835. So he, first of all,
how does someone, what?
Was there just not a lot on the curriculum back then? The like toe foot can turn into knee leg. That's all you need to know.
Yeah,
here's your piece of paper.
I think that must be it, because first of all, he was 22 coming out of medical school and was just going out on his own to practice. Think of like, you know, what you were like at 22, and I was very scared, you know.
An absolute hot mess.
Right.
Oh my God.
Yeah, and he graduated after 1 year. Like, he literally had never put his hands on any patients. He had never operated. He had just sat in a classroom.
The idea you can
it took
graduate
me 10 years
school.
to finish college.
Right. It took me so long to get a BLS. I can't remember. But it's so funny to me that you could graduate med school in 1 year and be regarded as fucking lazy. Like, no ambition. This dude kind of sucks. He's lackluster, but took him 12 months to learn everything there is to know.
Yeah, he graduates in 1 year and then becomes, you know, the epitome of gynecology, the father of gynecology.
Yeah, well, we're not there yet.
How crazy is that?
We're not there yet. So he goes back to Lancaster County in South Carolina to practice. And again, just to kind of give you like some context, nowadays, medical school comes after college, right? So you do 4 years of college, 4 years of medical school, and then you do 3 to 7 years of residency, because in medical school, you do a lot of book learning, you do some of your clerkships, but really in your residency is when you're practicing to becoming a doctor. And so this guy literally has never touched a patient before, and he just like kind of came out and was like, I'm a doctor. I'm going to start doing things.
Let me touch you.
Let me touch you. Yeah, exactly. And one of his biographies is actually really interesting. When I was reading this, one of his biographies literally said he had had no clinical experience, logged no actual hospital time, and had no experience diagnosing illnesses.
Oh my God.
Wow. This is medicine in 1835.
Medicine in 1835, guys. So very unsurprisingly, when he came out and he started practicing medicine in his home county, in Lancaster County, his first 2 patients died.
Oh my God.
Because
God.
Because he had no idea what the heck
It's
he
like
was
third
doing.
time's a charm. Come on, folks.
Oh my God.
So at the time, I mean, he did feel really bad about this, right? Like he felt really bad that his first 2 patients died, and actually was really sad. His first 2 patients were infants.
Okay, never mind. I shouldn't have joked about that.
But anyway, so
Should have started with that, Faye. What the heck?
sorry.
Oh my God.
So no, I mean, but he did feel bad. He was like, crap, like I clearly don't know what I'm doing. So he ended up moving away to Alabama, where he set up another practice. But in this case, he got married, and then he became what was known as a plantation physician because, of course, in 1835 in the South, there were a lot of plantations. There were a lot of slave owners and slaves. And in particular, the slaves actually needed a lot of medical care because they were often getting injured, or they would often be hurt by their slave owners, for example, because they would be whipped or they would actually be physically abused.
I'm going to go out on a quick limb here, and I know we don't get political on the show, but if you're pro-slavery, fuck you.
Oh my God.
You just turn off the podcast and go walk into fucking traffic, okay?
Absolutely. The reason he joined this plantation, he became a plantation physician, was that he actually had a lot of partners in a very large practice. And a lot of these partners were actually more experienced than him. So he kind of did like a little apprenticeship with these partners, right? So they knew a lot more than him. They would take him around the plantation. They would kind of show him like, okay, this is like what we do for this. This is what we do for that, etc. And pretty soon, he actually started to get pretty good at practicing medicine, and he became a surgeon where he began to operate for things like club foot, cleft lip, cleft palate, patients who had crossed eyes. And again, I'm glad that he got some experience under his belt. I'm glad that he's now able to do these things. But nowadays, this would be done by 3 different specialties. So these things would only be done by people who do those things. Like clubfoot would be orthopedics, cleft lip, cleft palate would be, ENT, and cross-eyed would be like ophthalmologist. So I'm still amazed that this guy who's got like 0 years of training just like came out, was like, hey, what up? And started operating on people.
So you're saying in today's medicine, no one can be a jack of all trades but a master of none, where you come in and you're like, hey, I am okay at that. I'll give it a shot.
Yeah. Oh, no. I've never done that before, but I'm a doctor, so you can trust me.
It's like if you walked into Ben's office and was just like, let me look at your eyeballs.
Exactly. Yeah.
It's like...
So anyway, he did get some training under his belt, and in 1840, he and his wife Teresa ended up moving to Montgomery, Alabama, another location in Alabama where they would live for the next 13 years. And in that short period, he then established himself as one of the largest surgical practices in the state and was described as immensely popular, greatly beloved. But it was also at this time, and this is where kind of the scarier stuff starts to come out, this is when he starts to experiment on enslaved women.
Oh my
Oh,
God.
bull.
No.
Oh, gosh.
Yeah.
Okay.
So in 1845, one of the slave owners that lived near him brought to him a patient that had something called a vesico-vaginal fistula. So we're going to break that down. So vesico-vaginal fistula is basically a hole that forms between the bladder and the vagina, which can lead to a connection between the two. And that leads to urine or your pee kind of just flowing freely out of the vagina. And that, obviously causes incontinence. So,
oh God,
as you can imagine, because of the fact that, these women are just leaking urine all the time, it's very difficult to keep clean, to keep hygienic, obviously.
How
this
common
can lead
is that?
to, we'll talk about this.
Oh God.
So, you can imagine this can be a source of embarrassment. It can lead to social isolation. Because, like, you know, it's for people, it's obviously very embarrassing to be walking around if they can't keep their continence. And then for a lot of these women, if it wasn't repaired, it can actually lead to scarring of the vagina. So it can lead to like pain, irritation, and eventually like the loss of vaginal function. So like not being able to have sex or anything like that. So it's obviously very distressing. So at the time, these vesicovaginal fistulas were actually pretty common, and it would happen because of a complication of childbirth. So what can happen in labor is that, you know, once the cervix, which is kind of the tissue at the bottom of the womb or at the bottom of the uterus, completely dilates, the fetal head or the baby's head is supposed to start coming down into your pelvis, and then you push and the baby is supposed to come out. But if there isn't a delivery soon and the baby's head kind of just sits in the pelvis because it's really hard to push that baby's head out, that head can actually compress a lot of the pelvic tissue, the soft tissue in your pelvis. And that includes the vagina, and it pushes the vagina against the bladder, and that cuts off the blood flow in that area. And eventually this leads to necrosis, which is tissue death. And then that eventually leads to this tissue just kind of sloughing off and leading to a hole or a trap that forms between the bladder and the vagina. So you probably are like, I haven't really heard of this before. Does this even happen nowadays? And yeah, it still can happen nowadays, but it's very, very uncommon because, of course, nowadays we have safe access, for some people, safe access to maternal health care. And also we're able to do C-sections, right? And so, you know, to give you some context, there are some patients who come to me and they're like, well, you know, why is it that once I'm completely dilated, how come I can't push for like 7 hours, 8 hours, 9 hours? Why is it that you doctors always want to do a C-section if I'm not pushing the baby out after X amount of time, like 3 hours, 4 hours, or 5 hours, for example? And I tell people, most people can't withstand 7 to 9 hours of pushing because that's a lot of hard work. Most babies, you know, they cannot stand 7 to 9 hours of pushing because that will stress the baby out and cause them to have oxygen deprivation and all of those things. But also, the reason that can't happen is because it actually is going to lead to things like vesicovaginal fistulas, where the head is down there for so long and it's compressing a lot of tissues. And the reason you don't see this a lot nowadays is because we have the ability to help people deliver their babies safely. And you don't have to be in labor where you're pushing for 7 to 9 hours or more, right? But yes, that's why we mean doctors recommend C-sections after a certain period of pushing, because we don't want you to develop complications like this.
Oh my
Robin
God.
often tells me how afraid she is of childbirth.
You look at Adam's head, okay? Guys, look
Both of our heads are huge.
They're
For the
huge.
record, I can fit her glasses on my head without stretching them, so you don't get to blame me for the huge head thing.
It's just, he has a huge head. I have a huge head. That baby's gonna be gigantic.
I'm sure everything is going to be fine when that
I'm sure everything's
comes.
going to be fine. And so, you know, when you hear people when they say like, oh, I was in labor for 24 hours, like, yeah, you were probably having contractions for 24 hours. The cervix was dilating, but the active part where you're actively pushing, that part was most likely not 24 hours. That part was hopefully less than a few hours. Because yes, your body can be in labor. You can be having contractions for a long time, but hopefully you're not pushing or completely dilated for 24 hours, because that's how bad things like this happen.
Oh my God.
Anyway, back to the story. I feel like we've taken a lot of like little
necessary informational detours.
Necessary information
And
that
pauses
horrifies
so that,
me.
yeah, she's not so horrified.
So anyway, Sims, this guy became fascinated by vesicovaginal fistulas, right? And he was like, this is my life's work. This is what I want to know how to cure. I don't really know why that was the thing that fascinated him. But you know what? Great. Good for him. He subsequently also became fascinated with rectovaginal fistula. So recto, rectum, vaginal, vagina. So a rectovaginal fistula is the same thing, but it's just a hole between the rectum and the vagina, which can also happen as a complication of childbirth in the way that I previously explained. So he then...
Oh my God. These are all so horrifying.
Don't worry. These things don't really happen that often anymore because, you know, hopefully you're not pushing or you're not having a baby's head sit in your pelvis while you're pushing that baby for that long.
what if you have a baby with the head like mine or where it's just god, I'm just horrified.
There is a thing called like cephalopelvic disproportion, which is a fancy way where we say the head is not going to fit out of your pelvis, ma'am. When that happens, that's when we
that baby's head is too huge. Sorry.
That's our medical way of saying that head will not fit out of your pelvis. And then that's when we would offer people to C-sections. Like if you're pushing and it's been a long time and the kid's head is not coming down.
Okay. I think it's funny that in that moment, our dog pushed her head through the office door to get in here.
So anyway, Sims became fascinated with these fistulas. He wanted to learn how to fix them. And then so he started to look for patients who had these fistulas on which to experiment on. And his thought was, these experiments weren't wrong because at the time there really wasn't a way to fix these rectovaginal fistulas or vesicovaginal fistulas. And these people were unfortunately living these very miserable lives where they were just incontinent all the time. And so while he did occasionally experiment with surgery to fix these fistulas on white women, his main subjects were 12 black women who were enslaved. And again, why? Wow. Because this was the 1800s in the South.
I'm sure that's like the easiest access for him.
Right, exactly. And in particular, 3 of these women were named in his autobiography. So he actually named 3 of the women that he did multiple surgeries on. And their names were Anarcha, Betsy, and Lucy. And each of them suffered from a fistula of some type. And so he would operate on them multiple times to try and correct their fistulas. And so just so you know, nowadays, now we can usually fix fistulas with 1 surgery. But in his case, Sims really had no idea what he was doing, right? And because of that, he operated as many times as 30 times on Anarcha.
Oh my God!
Before he deemed her surgery a success.
What? So he's just going in there, experimental surgery, just like he doesn't know what he's cutting. He's just doing whatever to figure out
putting stitches in wherever. She's done. They're like, oh, maybe it worked. And then she's still having symptoms. They go back, a few weeks later, try to fix all
Did they have that
things.
song back then where it's like, the knee bone's connected? Because I'm pretty sure there's a verse, it's like, the rectum's not connected to the vagina. And he's just God. Singing that while he's operating. Like, these 2 things don't go together.
Yeah. Maybe. I don't know.
I forgot how stupid Adam is.
Well, now I have this picture of this like man just like operating in this person's vagina and singing a weird song. So just to like kind of tell you how long these surgeries were, he would sometimes operate for so long on these women that his surgical assistant, so, he would have someone who's like retracting for him or holding things for him, that they would tire out. And then he would actually ask the patient to assist him to operate. And the way that he could ask the patient to assist him is because he did not use anesthesia on any of his patients during their surgeries.
Oh my God.
Yeah. And so even though anesthesia had already been invented and described in medical journals by 1846.
I would like to vomit.
Holy shit.
Yeah.
Oh my God.
So and some people argued, well, maybe he didn't know about anesthesia, right? It's 1845, 1846, it's just coming out.
He only had a year of
Maybe
med
he
school.
didn't know about that. But he was actually a very up-to-date doctor. Medical journals were a thing that were circulating at this time. And certainly he read very widely. And it would have been very strange for him not to have heard of these methods for anesthesia at the time. So using ether, using chloroform, all of that stuff. And then some other people would also argue, well, maybe anesthesia was experimental at the time, which it was. And so maybe the reason he chose not to use it was because he didn't think that it was safe, or he didn't feel that it was something that was necessary for those surgeries. But I also just cannot imagine, as someone who has a vagina, having someone operate on me for hours and hours with no anesthesia. You know what I mean? And so these patients must have expressed a lot of discomfort, a lot of pain during those surgeries for him to just say, oh, they don't need anesthesia. Nowadays, I just feel if a patient says something like, I feel pain, I just stop and I'm like, oh, more anesthesia is necessary. Or if the patient's moving, we're like, oh, more anesthesia is necessary. We can't do it. So it's just something that is actually very, very, it's revolting to me.
Yeah.
The biggest reason I think that he didn't end up using anesthesia was that there was a very racist belief at the time that Black people did not feel pain in the same way as white people.
What the
Oh my
frick?
God.
So that was just a widespread belief. And so he, probably thought, well, these women just don't experience pain the same way that I do or the same way that white women do. And so that was, I think the reason that he did not end up using anesthesia.
Racist.
The other scary things is that he made a lot of errors in terms of sanitation and infection. And one of his patients, Lucy, who I had previously mentioned, almost died from sepsis after he operated on her, one, without anesthesia, and also experimentally used a sponge to wipe urine from the bladder, and then ended up leaving the sponge in her bladder.
Oh my God.
What the fuck?
Yeah. I told you there was a dark side to this story. And the one thing that
This is horrific.
It's really actually horrible. The one thing that he did do, and at first I was like, oh, maybe he did have some compassion for these people, was he would give opium to his patients after the surgeries to help with the pain. But then some of his biographers actually said at the time it was normal for people to give enslaved people opium. So that because it was addictive, and so that it was a method to prevent them from running away in response to the excruciating pain of the procedure
Wow.
or like
That's
their
so
lives.
fucked up.
Because then they would have to be dependent on the slave owners, on the doctors, etc., to come back for more opium because it was so addictive.
Oh my God.
There were additional women that he also worked on that he didn't name in his autobiography, but remember when I said there were 12, there was a lot more that were listed. The other ones that were also significant to his work were Anne McCree, who was 16 when he operated on her, Lavinia Boudrant, who was 13 when he operated on her,
What?
Delia, who was 23, and Julia McDuffie, who was 20. And so obviously you can see how young some of these patients were. Some of them were obviously children. And a lot of times the other way that you could get a vesicovaginal fistula from childbirth was actually from sexual abuse. And a lot of these enslaved women were actually being abused by their slave owners.
Yeah, I could see that.
This is so horrifically disgusting.
This is
in so
definitely,
many
yeah,
ways.
right? It's like there's levels to this horror. Like, this is definitely.
It's like, I would like to present you with a horror onion. I'm going to peel the layers, and each layer is more horrific than the last.
Than the last, yeah. So eventually he would finally perfect his technique in 1849 when he began to use silver wire as suture instead of silk or lead, because silver wire would avoid infection and it could also avoid poisoning. And when he first successfully repaired a vesicovaginal fistula, it was in Anarcha, and then he began to repair more fistulas on other Black women. And because of his success after 1849, there was actually a lot of white women who then asked for his help in the repair of their fistulas, but actually most of them were not able to endure the pain of the operation, and so ended up not going through with it. And so you can imagine how excruciating this procedure is, how horrible it was that some of these people would endure these procedures multiple
Dude.
times, including Anarcha, who had these procedures 30 times. And then even as late as 1857, he would still insist that he never used anesthesia to perform fistula surgeries because the procedure just wasn't painful enough to justify the risk of administering
Wow.
anesthesia.
Okay, no. When I get my nails done, if the person doing my nails just nicks me a little bit, I'm like, what the fuck? You know what I mean? I can't imagine a doctor literally cutting into me and being like, it's not that bad. You know what I mean? Like, no.
So you're saying the father of gynecology wasn't a good guy?
He was not a good guy.
Oh my God.
Really not a good guy.
This is just unfucking real. Is it weird that I'm provided some relief that at least when he started providing these surgeries to white women, he still wasn't doing anesthesia? Because to me, that means that he was like
Equal opportunity.
equally awful. You know what I mean? Like,
Yeah.
It wasn't just specific to like test subjects. He had just become convinced, like, oh, this thing is like, it's women I don't care about, not just Black women. Like, it's so horrific on so many levels that I'm just like searching for something to be less horrified about.
Yeah, I mean, I think that, when we get to the end of the story, we'll talk about how this is still actually reflected in a lot of procedures that have to do with women nowadays. But we'll get there. I've still got a little bit more about how horrible this guy was.
Okay, I'm going to put myself back in the horrible mindset. Go ahead. Lay it on us.
Okay, so there were some redeeming qualities to him. He moved to New York after some time. He established the Women's Hospital there. It was the first hospital for women in the U.S., and he treated mainly poor immigrant women and did, eventually receive a large grant from the state. So he did actually provide care, free care, to a lot of poor immigrant women that were coming to him. So I think in his mind, he was like, I'm doing great things. So despite what was actually considered some good work for him, he was very much a Confederacy sympathizer. He was from the South, right? So in 1861, as the American Civil War drew near, he ended up having to leave his practice because he was like, I cannot continue to live in the northern parts of the United States. He moved to Europe because he considered himself a loyal Southerner. He stayed in Europe. He continued to practice medicine there. He even treated Empress Eugenie, the Empress of France, who was married to, I think, like Napoleon III or something at the time, for her fistula. It doesn't say, though, if he used anesthesia for her or not. And then in 1865, when the 15th Amendment was passed, which was, again, the amendment that ended slavery, he still commented that it was a dreadful mistake to give the Negro the franchise.
What the frick?
Got
This
it.
guy is just, brother,
It's so, like,
Like,
I get it. It's
I
1865. He's a person of the times. It's where he grew up. You still have to have some level of just pure evil built into you to look at a black person and just insist, like, I don't think that they deserve their freedom. And in so many cases, like, even in this story, it's like, I view them as a different kind of species. That's so fucked up of a mindset to have. It's so bizarre.
So, as someone who is considered like a big deal in the medical community, has anyone ever come out and been like, yeah, okay, he's a big deal, but can we name this speculum after someone else?
Yes.
Or something else?
Yes. I will come to that. You guys are like anticipating all of my little story beats.
I think Robin's
So that's
asking
really
all
great.
the right questions
Yeah,
here.
you are asking all the right questions. So we'll come to that. So basically, just to kind of end his life story, all right? He had an international reputation. He got lots of awards and medals. He was elected president of the American Medical Association in 1876. Eventually dies in 1883. But he, at the time, was considered like the epitome of what you could be as a doctor. He was someone that people emulated and was like, you have this international renown for being this great doctor and fixing this thing that was plaguing women. And you are, to be lauded, or you're supposed to be like applauded for all of this stuff. And because of all of this, I think ultimately he set the example of how the establishment has treated Black women and women in general throughout history, right? So, clearly we learned a lot of valuable techniques from him in the gynecological surgery, but we should remember that he and many doctors in the South at the time were actually incentivized through the system of slavery. A lot of these doctors employed slaves, they traded slaves, they did their medical research by experimenting on it and exploiting the slaves that they owned. And then if, you can say, well, maybe, yes, these were problems that we couldn't cure before, but now we could cure. I think it's also we need to remember that we wouldn't be able to cure a lot of these issues nowadays if it hadn't been for those enslaved people. And so I would argue that we shouldn't just remember J. Marion Sims for treating vesicovaginal fistulas. I think we should remember Anarcha. We should remember Betsy. We should remember Lucy.
The people
right?
who endured the pain and 30
Right.
operations, like, they're more important than the person who decided it's okay to experiment on a human. And
Yeah.
it's shocking to me how many folks would not make that connection, but can do that when you talk about experiments done by the Nazis during World War II. And in this particular case, I don't think I've not heard of this.
Yeah.
I just, talked about the Nazi experimentation, which I've obviously heard of. And this shit happened in my fucking country.
Yeah.
Like, that's horrifying.
It's horrifying. And I think, nowadays we still, as a medical community, think that women potentially don't feel pain for a lot of the procedures that we perform on them. So one of the big things that I think people have come out to say is like IUD insertions, right? IUD intrauterine devices like the Mirena, the Liletta, all of those things. IUD insertions are incredibly, incredibly painful and uncomfortable. And people are not given anesthesia. Like, these procedures are done in the office. Like, we just insert them in the office. People are not given medications. This is not done under anesthesia. Oftentimes, we are initially taught the cervix doesn't have any sensation. And so, you'll feel cramping, but you won't feel, for example, like pain. But that's actually just not true. And so nowadays we are actually more aware of this, and patients are coming out and advocating for themselves. More doctors are prescribing people like a higher dose pain medication. They're numbing the cervix before they place the IUD. You don't necessarily need to undergo general anesthesia potentially to get an IUD placed, but here are all the other ways that we can numb the area or do it under local anesthesia. And I just want to highlight that this is very different when it comes to the same types of procedures that are performed on men. So for example, like, men will get Valium and they'll get local numbing and everything for vasectomies, which is a very, very non-invasive procedure that's performed. But like, women can't even get like numbing medications for their IUDs, where you're basically pushing a device into the uterus.
That is.
Oh, I can't even imagine like not getting any sort of anesthesia. I know, in the past when I've gotten like an implant, right? They numb my whole entire arm area before they even cut into me, and it's just this tiny little thing, but they still give me anesthesia. I can't imagine somebody sticking something that far into someone and not getting any anesthesia for it. That is insane.
Yeah.
That's insane.
Can we just like switch up how we handle this stuff and have female doctors perform experiments on men with no anesthesia and be like, hey, I'm going to jam this up your dick hole. And I've heard it doesn't hurt. And then see how fast that shit changes.
I mean, part of this is like why, like, when I gave birth, I really wanted to have an epidural, and people are always like, and I understand, like, not having epidural for some people is very empowering and everything, right? And I was like, no, childbirth hurts. Like, I'm not going to be like, what does that feel like? I'm never like, oh, when you pull my tooth, don't give me any of the lidocaine. Don't give me any of the numbing medication. I just want to see what it feels like. Like, I'm not going to do that. So, like, similarly with childbirth, like, no, give me the good stuff. I don't want to feel the pain. Like, that's okay. That's, but that's just me. Obviously, some people, like, they don't want the epidural for certain reasons, which is fine. Totally up to them. But for me, I'm like, we have invented this nice thing that takes the pain away. I'm going to take advantage of that.
Yeah, I always tell Adam, like, if they ask, make them give it to me.
I think she always expects me to be like, no, don't you want to have like a natural child? I'm like, fuck that. Give her two. I don't give a shit. Like, it's completely up to you how you want to handle that.
Oh, man. The fear.
But anyway, so there's a lot more to the story of J. Marion Sims. He's actually like done work in anesthesia itself, which is what is really surprising to me.
Oh my God!
He's done work in like tetanus, all of this stuff. But anyway, we don't have time to talk about that today. I just think that part of the story that I come on to tell is to kind of just tell you about like some of the scariness that happens in our own history in the US that we are not taught, that, I'm not taught as a medical provider, that I have to personally go out and search for myself. But it's one of those things where I think, like, again, we need to be cognizant of our own history and not just point fingers and say like, oh, look at those, bad Nazis in Germany. Look at those, like, people who commit genocide in this country, and realize that like we have all these like really scary things that happen in our own country that we may not have learned about, and we should know about because it is part of our history. And as you said, Robin, I think one of the other things is I want to bring awareness to the people who he experimented on, because I think they are just as important, if not more important, in the discovery of like the techniques that we use nowadays in these types of surgery. When we don't remember them, I am always like reminded of how when we tell the stories of serial killers, like we always remember the serial killer's name, but we like never remember the names of their victims. And I'm like, I mean, I'm guilty of this too, but I'm like, that's wrong. Like, we should remember those victims, and we shouldn't just like commemorate and like, almost like talk about these serial killers like they're celebrities.
That's such a good point.
Yeah. So to do this, actually at my previous hospital, where that hospital, like, people there were doing a lot of work to try and reverse some of the medical racism that has been in our history, they actually renamed the Sims speculum to the Lucy speculum. So I was very happy about
that's
that.
really cool.
Yeah.
That's super awesome. You built it steadily, and it was a nice climb on Horror Mountain until we ascended the top.
Yeah.
But you did a great job. This is the other thing too. Is like when people try and make that argument of like, why would you only focus on that? It's like, well, you didn't. Like, you talked about the medical advancements that came from these things, and it does open up that conversation of like, do the ends justify the means? And when you hear these horrible things like, well, no, they straight up fucking don't, and maybe there's better ways to do things, and that's the conversation folks should have. So this was fascinating. Thank you so much.
Yeah, of course. Thanks for having me back on your show. I love coming on and telling you all these stories that I am also learning, because this is my area of interest, and it's uncomfortable, but it's also liberating to learn some of these stories.
Yeah, I think it's incredibly important to know too. And hopefully I didn't sound too stupid, but I just want to make sure I ask questions, because I don't know. 70% of our audience, based off of all the demographics that we can see, is female. And so, like, I speak for the 30% of the idiots out there who didn't know what you guys were talking about, because I just have no experience with it from that side of things. So
Yeah, you guys don't have to have ducks, open you up.
no, we really don't.
Yeah, it's I always love these episodes with you because it's things that we wouldn't normally research and learn, and I think it's important, especially me as a woman, to know, the history of certain things. And I hope other hospitals, not just the one you used to work at, get on that train of renaming things appropriately.
Yeah. I mean, and I think, like, what I'll do is, like, if I see this speculum at my hospital, I'll just be like, hey, by the way, we're calling these Lucy's now, and hopefully, like, change the culture where I'm at, right?
Yeah, why not? I mean, it's like, you can give something a name, you can take it away, you can change its name. There's nothing wrong with it. And there's like everything right with it in this particular case. So, well,
thanks again, you guys, for having me on your show. I always have a lot of these very horrifying medical stories. So if you want to hear more, just let me know.
We literally always want to hear more. So feel free to reach out to us if you're like, I think I want to be on Scaryish this week. Just message us, and I will crumple up my script and throw it in the fucking trash.
No, please don't do that. Save it for the week after or something. I want to listen.
All right. Okay, cool. But seriously, you're always welcome back on the show. These are fascinating topics. It's always great to hear. Your personal stories are like mind blowing as well. And thank you for sharing that one with us. It's super intense and super powerful. And I think that'll really be a great thing for people to listen to. So right on. That's everything I think we're going to have for this episode 295 of Scaryish. One more last time. Big round of applause. All the spooky fans out there, clap your hands for Faye. Thank you so much for coming on the show.
Oh, you're not actually sorry.
No, I wasn't going to do it, but I'm glad you did it. So if anyone has a story that they would like to share with us, doesn't necessarily have to be about this specific topic that we covered, but hey, if it is, great. Feel free to email storytime@scaryish.com or go to our website, scaryish.com. Click on Contact Us, fill out that form. It comes directly to us, or hit us up on our socials. Twitter is @ScarishPod, Instagram is @ScarishPodcast, and Facebook is facebook.com/ScarishPodcast. Robin, for folks who would like to donate to us, how can they do so?
You can go to patreon.com/ScarishPodcast or coffeeko-fi.com/ScarishPodcast.
Cool. Yeah, thank you again one more time, Faye, for coming on. Thank you to everyone who listens, supports us in all the different ways that you support us. Before we leave, Faye, you're on a lot of shows. Please toss out anywhere people can come and listen to your brilliance.
What do you want to add? Tell us what you're working on.
Yeah, give us your plugs, promos, what's going on in your life. What do you want to promote?
Sure. Yeah, I feel like I'm working on a lot less stuff nowadays because, a baby is actually a lot of work. But I'm still doing How the Quest Was Won, which is a D&D actual play podcast. So come and check us out. We are found wherever you find your podcasts. I'm also working on Careers Over Coffee, which is our medical podcast about OBGYN. It's more about like topics directed for OBGYN providers. So not necessarily for the layperson, but hey, if you want to hear other things, that's pretty cool. You can come also check us out wherever you find podcasts.
Cool. Thank you again one more time. Sincerely appreciate you coming on. And yeah, that's everything we have for this episode. So, Robin, do you want to make Faye do the sign out?
Yes, let's have Faye do it.
Sign us out.
All right. Keep on creeping on.
And we'll talk to you next week.